Welcome everyone to the first session of Select Data's OASIS training. My name is Deborah Johnston and I am your host today. Material during this series will be delivered by members of the Select Data Clinical Leadership Team. Before getting started, I'd like to remind you of our disclaimer. Information made available from this webinar should not be considered legal advice. It is for educational purposes only and does not provide all available information on the subject. Information shared is not a promise or warranty, guarantee, expressed or implied. The opinions expressed, discussions undertaken, and materials provided do not represent an official position of Select Data. Today's session focuses on 3 foundations of home health care. They include the conditions of participation, Chapter 7 of the CMS Benefits Manual, which addresses home health care, and finally the OASIS conventions, which are basically the ground rules for completing the OASIS assessment in a compliant manner.
Thank you, Debbie. The first part of the Home Health Foundation is the conditions of participation. They outline the practices that must be followed for all patients being treated by a home health agency approved to receive Medicare funding. Traditionally, healthcare has been delivered in a manner that focused on the patient's deficits that required treatment. Providers assessed the patient's conditions and then came up with a plan to address those conditions. This focus limited the patient's role to being a passive recipient and consumer of healthcare. For many years, the flaws in this traditional model became evident, and healthcare has very slowly begun shifting its focus to making patients active participants responsible for their health maintenance. The changes and updates to the home health conditions of participations that took effect in 2017 clearly align with this philosophy of care. During this session, we are going to focus on 3 aspects of the home health conditions of participation, and those will include the patient rights, the comprehensive assessment, and care planning. Who can exercise the patient's rights? In the conditions of participation, there are multiple references to the patient's representative. The patient's representative is someone the patient chooses to participate in their care. It can be a spouse, another relative, or even a friend. A patient who has the legal right to make their own healthcare decisions may choose to share that decision-making responsibility with someone else. If a patient has the legal right to make their own healthcare decisions, they can choose whomever they want to be their representative. The patient ultimately has the final say in their care, but they may choose to let their representative weigh in on those decisions. Things are different with a patient who, for whatever reason, has been found by the court to not be able to make their own healthcare decisions. In these situations, the court appoints a legal representative. When you have a patient in this situation, the legal representative has the final say in the patient's care. As a clinician, you must know what category your patient falls into. This is usually and hopefully communicated at the time of referral. You're required to communicate with the patient's chosen representative and the patient's legal representative if one is appointed. For decision-making purposes, you must know and confer with the person who is legally responsible for the patient's care. Written notice of patient's rights. When a patient is legally allowed to make their own healthcare decisions, all patients are to have that written notice of their rights. It needs to be given to them before care is initiated at that first visit. The patient's signature must be obtained to verify that they have received this notice of their rights. At that first visit, the patient should be asked who their representative is. If that representative is not physically present at that first visit, You are allowed 4 business days to give the representative notice of the patient's rights and get their signature verifying that they have received it. The rights can be taken to the representative or sent via mail or email if they have that available. If the patient is legally unable to make their own healthcare decisions, then the patient's legal representative must be made aware of the patient's rights before you provide any care to that patient. If the legal representative is present at the start of care, you should give them the written notice of rights and obtain their signature before care is provided for the patient. If the legal representative is not physically present at the start of care, you must speak to them by phone or give them a verbal explanation of the patient's rights and document that verbal explanation was given. They must receive this explanation before care is initiated with the patient. In that situation, you still must provide the legal representative written notice of the rights and obtain their signature within those 4 business days. Along with written notice of the patient's rights, you are required to give a verbal explanation of the patient's rights. This doesn't mean that you have to read the patient's rights word for word to the patient. You should verbally review the patient's rights with them and make sure they understand what the rights consist of. When this verbal explanation of rights is given, you must document this in the clinical record for the patient. Ideally, it seems like it would make the most sense to do this at the first visit after the patient is given the written rights. However, CMS understands that there are situations where it may not be practical for that explanation to be given at that time because the situation doesn't always allow for it, or the patient may become overwhelmed with everything that is involved with that start of care assessment. However, that verbal explanation must be given to the patient by the end of the 2nd visit. The patient's representative also should be given a verbal explanation of the patient's rights by the end of that 2nd visit. If the representative isn't present for that visit, they should be contacted via phone, and then that can be documented. If a patient has a legal representative appointed by the court to make their medical decisions, the legal representative should be given this verbal explanation. You must be aware that if there is a court-appointed representative for a patient, that legal representative must receive either a written explanation of the patient's rights and or a verbal explanation of the patient's rights before you provide care for that patient. This will not be a problem if the legal representative is present at that start of care visit, but if they're not, you at least have to give them a verbal explanation and document that they receive that explanation before you assess the patient. If the legal representative cannot be reached, CMS expects that you will postpone that start of care assessment. As we're wrapping up the rules surrounding the patient being informed of his or her rights, there are 2 situations I want us to address. If a patient has a disability that makes understanding of written or verbal information difficult, you must make this information available to them in a manner that is understandable to them. This includes utilizing websites and the provision of auxiliary aids and services at no cost to the individual, in accordance with the Americans with Disabilities Act. If a patient has limited English proficiency, they have the right to be notified of their rights and have communication about their care delivered in the language of their preference and have this provided to them at no cost. This may include oral interpretation utilizing an interpreter phone service and written translations of any of the agency's written information. Your agency must have a plan in place for communicating with persons who speak in languages other than English. The patient's family is not required to provide this interpreter. It is the agency's responsibility to be sure that they're able to communicate with all of their patients. Okay, let's move forward to the actual patient's rights. They fall into 5 broad categories: physical safety and protection of property, delivery of medical treatment, the treatment plan, making complaints, and rights regarding transfer and discharge. The patient has a right to have his or her person and his or her property treated with respect. The COP states, the patient has the right to be free from verbal, mental, sexual, and physical abuse, including injuries of unknown source, and be free from neglect and misappropriation of property. Any home health agency staff in the normal course of providing services to patients who identifies, notices, or recognizes incidences or circumstances of mistreatment, neglect, verbal, mental, sexual, and or physical abuse, including those injuries of unknown source or misappropriation of patient property, must report these findings immediately to the home health agency and other appropriate authorities in accordance with state law. An injury of unknown source means the source of the injury was not observed and cannot be explained by the patient. And the injury is suspicious because of the extent of the injury, the location of the injury, or because there are a number of injuries observed at a particular time, or because of the recurrence of injuries. Patients have the right to participate in, be informed about, and consent or refuse care. The patient can refuse care before the treatment is given or during the treatment. The patient should receive written notice about the clinician's scheduled visits and frequency, what disciplines will be furnishing care, the care to be furnished based on the comprehensive assessment, medication instructions, and the expected outcomes of care and treatments to be furnished by the home health agency. The patient's written instructions should also include the clinical manager's contact information in case the patient has clinical questions or concerns. The clinical manager is the designated person in the agency who is assigned to oversee the plans of care and coordination of care for all patients. The COPs require that such a person be designated by the home health agency's leadership. The patient has a right to receive all services outlined in these written instructions about their plan of care. The patient has a right to have a confidential clinical record and the right to request access to or release of patient information and the clinical records. Upon request, the patient must receive a copy of their clinical record, either in written or in electronic form, at the next home visit or within 4 business days, whichever may come first. The patient has the right to be advised of what portion of the cost of their care they may be billed for outside of their insurance benefits before that care is initiated. The home health agency must notify the patient or the patient's legal representative of any such potential charges as soon as possible in advance of the next home health visit. The patient also has the right to written notice about the reduction or termination of services by the home health agency. The patient also has the right to be informed about how to contact state and federal advocacy agencies. You must provide them with the phone numbers for the home health telephone hotline, the Agency on Aging, the Center for Independent Living, the Protection and Advocacy Agency, the Aging and Disability Resource Center, and a Quality Improvement Organization. The patient has the right to make complaints to the home health agency regarding treatment or care that is or fails to be furnished, and the lack of respect for property and or the lack of respect for the person by anyone who is furnishing services on behalf of the home health agency. The home health agency must provide the name and the contact information for the administrator of the agency so that these complaints can be communicated and an investigation into the complaint is launched. In response to these complaints, the agency must investigate the complaint. They must document the complaint and the resolution of the complaint. The agency needs to take measures to prevent further violations and retaliation while the complaint is being investigated. And they need to guard against any discrimination or reprisal toward the patient for making the complaint and provide access to auxiliary aids and language services to foster communication regarding such complaint. The patient also has a right to be informed about your agency's policies regarding transfer and discharge of a patient. Agencies can transfer or discharge a patient when the severity of the patient's condition or illness makes them unsafe to be cared for at home by a home health agency, or if the patient's insurance will no longer pay for home health agency services, or maybe the physician and the home health agency agree that the patient's measurable outcomes and goals have been met. Also, the patient refuses services or elects to be transferred or discharged, if the patient dies, or if the home health agency closes. A patient can also be discharged for cause. This means the patient or someone in the patient's home demonstrates behavior that is disruptive, abusive, or uncooperative to the extent that delivery of care to the patient or the ability of the home health agency to operate effectively is seriously impaired. If a patient is to be discharged for cause, the following steps must be taken. The agency must advise the patient, representative, and physician who will be responsible for patient's care after discharge, and that the patient is being considered discharged for the specific reason. The home health agency should make efforts to resolve the problem. They should provide the patient and the representative with other potential home health agencies and providers, and they must document the problem. So now let's talk about the comprehensive assessment, and this is something we're familiar with already. So please note that the COPs require that the comprehensive assessment include the patient's strengths, goals, and care preferences, including information that may be used to demonstrate the patient's progress toward achievement of those goals identified by the patient and the measurable outcomes identified by the home health agency. The comprehensive assessment documentation should also include the patient's caregiver, if any, and available support persons, including their willingness and ability to provide care and their availability and schedules. If part of the patient's plan of care includes caregiver training, then you would expect to see visits scheduled in accordance with that caregiver's availability. CMS expects that a patient's comprehensive assessment will be updated at times of recertification or sooner if a change in condition occurs. Agencies are expected to develop policies and procedures that establish the parameters for what constitutes a significant change in condition. CMS believes that extended emergency room stays, patients who are in the hospital on observation status, and patients who are accessing urgent care are all experiencing a significant change in their condition, and that would warrant a patient assessment. CMS closely scrutinizes the plans of care to assure that they are individualized based on the patient's strengths, goals, and care preferences. Plans of care must include measurable outcomes and a plan for patient and caregiver education and training. The plan of care should be updated as a patient's condition changes, and if a comprehensive assessment becomes necessary because of a condition and change, you would expect for the plan of care to be updated in light of those changes. All drugs, services, and treatments planned must be in accordance with the physician's orders. Any verbal orders obtained must be done so in accordance with state regulations and are expected to be signed, dated, and timed by the clinician taking the order. The most recent version of the COP specifically addresses coordination of care. If a home health agency chooses to take orders from more than one physician for a particular patient's care, the agency assumes the responsibility to communicate the plan of care and any changes to the plan of care to all physicians involved in the patient's care. The agency is also responsible for integrating orders from all physicians involved in the plan of care, to integrate services for the patient, and to coordinate care delivery and to ensure that patients and caregivers receive all necessary education and training necessary to facilitate a timely discharge. It is expected that this level of coordination will be overseen by the designated clinical manager assigned with the patient's plan of care. Now we are going to shift over and review Chapter 7 of the Medicare Benefit Policy Manual. This chapter focuses exclusively on home health providers. Chapter 7 covers many topics regarding home health care. So for our purposes today, we will focus on two of these topics. The first being what services qualify for Medicare reimbursement. The second topic explores what requirements must a patient meet in order to be admitted into home health care being provided by Medicare. The Medicare contractor's decision on whether care is reasonable and necessary is based on information reflected in the Home Health Plan of Care, the OASIS as required by federal regulations, or a medical record of the individual patient. Coverage of skilled nursing care or therapy to perform a maintenance program does not turn on the presence or absence of a patient's potential for improvement from the nursing care or therapy, but rather on the patient's need for skilled care. Skilled care may be necessary to improve a patient's current condition, to maintain the patient's current condition, to prevent, or to even slow further deterioration of the patient's condition. Services that qualify for Medicare reimbursement that may be included in a plan of care include part-time or intermittent skilled nursing care. So this is services other than solely venipunctures for the purposes of obtaining a blood sample for lab work. Will also include part-time or intermittent home health aid services, physical therapy, speech language pathology, occupational therapy, or medical social services. Also covered are medical supplies. So this will include catheters, catheter supplies, ostomy bags, supplies that are related to ostomy care, and a covered osteoporosis drug, but excludes other drugs and biologicals. Durable medical equipment is covered while under the plan of care established by the physician. Medical services provided by an intern or resident in training under an approved teaching program of the hospital in the case of a home health agency which is affiliated or under common control with the hospital are covered. And then finally, services at hospitals, skilled nursing facilities, or rehabilitation centers when they involve equipment too cumbersome to bring to the home are covered. There are some patient requirements for Medicare-funded home health care, and this includes for the patient to be confined to the home. The patient must be obviously under the care of a physician. They must be receiving services under a plan of care that has been established and periodically reviewed by a physician. and the patient must be in need of skilled nursing care on an intermittent basis, or physical therapy or speech-language pathology. And the patient must have a continuing need for occupational therapy. Whether a patient is homebound, also referred to as confined to the home, can sometimes be confusing, and CMS gives specific criteria that must be met on that topic. So for the first criteria we'll look at is the patient must either because of illness or injury, need the aid of supportive devices such as crutches, canes, wheelchairs, and walkers, the use of special transportation, or the assistance of another person in order to leave their place of residence. So that would be one criteria that would support that homebound status. Or if the patient has a condition such that leaving his or her home is medically contraindicated. So if the patient meets one of those two conditions, then the patient must also meet two additional requirements defined in criteria that we're going to discuss next. There must exist a normal inability to leave the home, and leaving the home must require a considerable and taxing effort. So just to clarify, to be considered homebound or confined to the home, the patient must meet one of the requirements in the criteria 1 category and both requirements in the criteria 2 category. So if a clinician, upon beginning a start of care visit with a patient, finds that they are in a situation where they're unsure if the patient meets these requirements, it is advised that they immediately contact their supervisor for next steps. If the patient does in fact leave their home, the patient may nevertheless be considered homebound if their absences from the home are infrequent or for periods of relatively short duration or attributable to the need to receive healthcare treatment. If the patient does in fact leave the home, the patient may nevertheless be considered homebound if those absences from their home are infrequent or for periods of relatively short duration, or if those absences are needed to receive healthcare treatment. So in those instances to receive that healthcare treatment, that would include but not be limited to attending an adult day center to receive medical care, or if they have ongoing outpatient kidney dialysis, or maybe the receipt of outpatient chemotherapy or radiation therapy. However, occasional absences from the home for non-medical purposes does not always necessarily indicate that the patient isn't homebound. So occasional absences such as taking a trip to the barber, a walk around the block or down the driveway, attendance to a family reunion, a funeral, or a graduation, something infrequent or unique, those are allowed to still be captured under that homebound category. It's just if the absences are undertaken on an infrequent basis or are of relatively short duration, then that patient would still qualify. These occasional, infrequent, and short departures from home do not necessarily indicate that the patient has the capacity to obtain the health care provided outside rather in the home. If a clinician is unsure about a particular situation that they may run into, they are advised to directly consult Chapter 7 of the Home Health Benefit Manual and or consult with their supervisor. Please be aware that unwillingness by a patient to leave the home does not equate to the inability to leave the home. So just a side note on that. The aged person who does not often travel from home because of frailty or insecurity brought on by advanced age would not be solely considered confined to the home for purposes of receiving home health services unless they meet one of the above conditions that we discussed. Although a patient must be confined to the home to be eligible for covered home health services, Some services cannot be provided at the patient's residence because equipment is required that cannot be made available in the home. If the service is required by an individual involve the use of such equipment, the home health agency may make arrangements with a hospital or skilled nursing facility or a rehab center to provide those services on an outpatient basis.
We have arrived at the final pivot in this session where we will review the OASIS conventions. The following slides reviews the conventions or general rules that should be observed when completing the OASIS. Item-specific guidance is provided in Chapter 3 of the OASIS Guidance Manual. The OASIS guidance is updated periodically to provide additional clarification based on frequently asked questions sent to CMS. A link to all the frequently asked questions is provided in Chapter 5 of the manual. It is not possible to address all of the situations that arise due to the rare and unique nature of some of the questions and the exceptions that may be encountered in clinical practice. Each patient scenario, clinical status, social and environmental situation is unique, requiring professional and clinical judgment and care coordination. In the event that you cannot resolve your understanding of an OASIS question, CMS will continue to provide avenues to accept and respond to questions. The first OASIS convention regarding the time period under consideration. Please be aware, as was mentioned in the previous slide, these conventions are to be followed throughout the OASIS unless there is specific guidance given for a particular item. Now, this first item about the time period under consideration. You will report what is true on the day of assessment unless a different time period has been indicated in the item or related guidance. The day of assessment is defined as 24 hours immediately preceding the home visit and the time spent in the home by the clinician. So, skills check. If a nurse does a start of care visit with Mr. Zilk on April 15th from 1 p.m. to 2 p.m., what time period is considered to be the day of assessment for OASIS purposes? In this scenario, the day of assessment is considered to be April 14th from 1 p.m. through the end of the start of the care visit. Here's another example of a time period under consideration. Now, in the previous slide, we stated that unless the clinician is instructed otherwise, the time period of consideration for OASIS items is the time of the start of care assessment and the 24 hours preceding the visit. Now, keep in mind, there are several items that do specifically specify a different time period. M1600 is an example of this. This specific item asks, has the patient been treated for a urinary tract infection in the past 14 days? Now, in this item, a different time period is clearly identified. You would review the patient's health status for over the last 2 weeks rather than just the day of assessment. Next OASIS convention that defines a quality episode. For OASIS purposes, a quality episode must have a beginning, that is, a start of care or a resumption of care assessment, and it must have a conclusion, and that would be a transfer, discharge, or death at home assessment to be considered a complete quality episode. The third OASIS convention regarding usual status. If the patient's ability or status varies on the day of assessment, report the patient's usual status or what is true greater than 50% of the assessment time frame unless the item specifies differently. There are several conditions that can impact a patient's ability to perform different actions throughout the day. A patient might have pain that prevents them from participating fully in their physical activities at different times of the day. Other patients may have varying degrees of mental clarity throughout the day due to cognitive decline. In such cases, asking the patient and caregiver questions is key in determining what is the usual status. You could do this by asking questions like, is your pain worse during certain times of the day? Or, do you find yourself to be more confused during certain times of the day? Finding out these details can assist the clinician in determining what is true for the patient more than 50% of the day. It is worth the effort to invest the time in a thorough assessment for OASIS accuracy. Skills check. Mrs. Lutz has arthritis pain daily. Her waking hours are typically 8 a.m. to 10 p.m. Upon waking each day, she takes her morning medicines, and that includes a medicine for pain. Until around 11 each morning, she refrains from bathing, grooming, and dressing because of the pain in her hands and her legs. She explains to the clinician, by 11 o'clock, my pain medicine gets in my system and I can get up, get dressed, and start my chores. I usually keep busy until about 7:30 when I sit down to watch Wheel of Fortune. As the clinician, you will want to take into account Mrs. Lutz's ability to perform her ADLs based on what is true more than 50% of the day. While she is inhibited by pain for the first few hours of the day, the majority of the day she is able to perform her ADLs and IADLs. You would score, or in other terminology, code her OASIS items based on what Mrs. Lutz can safely perform for more than 50% of her day. The next OASIS convention regarding the NA and unknown responses. Using responses such as NA or unknown should be minimized per CMS guidelines. OASIS convention regarding using a dash. Some items allow a dash response. A dash value indicates that there is no information available. CMS expects that a dash will be used as a very rare occurrence. Next OASIS convention regarding documentation based on the time of assessment. Responses to items documenting a patient's current status should be based on observation of the patient's condition and ability at the time of the assessment, without referring back to prior assessments or documentation of status from a prior care setting. Several process items require review of documentation of care that occurred at a time of or at any time since the most recent start of care or resumption of care OASIS assessment. These instructions are included in item guidance for the relevant OASIS items. OASIS convention regarding observation, interview, and collaboration with the agency staff. Combine observation, interview, collaboration, and with other agency staff and other relevant strategies to complete any and all OASIS items as needed, unless otherwise noted in the guidance. For example, it is acceptable to review the hospital discharge summary for information on a patient's episode of confusion, or to interview the caregiver regarding the patient's incontinence. However, when assessing physiologic or functional health status, direct observation is the preferred strategy. OASIS items about the definition of assistance. The convention states that when an OASIS item refers to assistance, this means assistance from another person, another human being. Assistance is not limited to just physical contact either. Assistance can include necessary verbal cues and or supervision. The 9th OASIS convention about accuracy, comprehensiveness, and skip patterns. Complete the OASIS items accurately and comprehensively and adhere to skip patterns. Next, about understanding the language of the OASIS. This convention states that you should make sure that you understand the definitions of words that are used in the OASIS. This is the only way for you to assure that you're making accurate responses in the documentation. OASIS Convention 11, following the rules included in the specific guidance. The clinician filling out the OASIS assessment should follow the rules that are indicated in the specific guidance, which is Chapter 3 of the OASIS Guidance Manual. The next OASIS convention regarding remaining current. Stay current with the evolving CMS OASIS guidance via updates to the guidance manual and posted Q&A documents. These reference items, the OASIS guidance manual and the documentation of the quarterly Q&As, are available for free on the CMS website. The OASIS guidance manual can seem intimidating to clinicians who are not familiar with it because it's a very large document. Don't let that discourage you from using it. It's divided into large sections. All OASIS-specific guidance is found in Chapter 3. In Chapter 5, you will find many helpful links to reference materials. To access the quarterly Q&A questions, you simply need to do an internet search for the terms CMS, home health, and quarterly Q&As. OASIS Convention regarding collaboration when appropriate, and the OASIS item M0090. The comprehensive assessment includes the OASIS items and is part of the patient's legal home health agency clinical record. While only the assessing clinician is responsible for accurately completing and signing a comprehensive assessment, she, he, or they may collaborate to collect data for all OASIS items if the agency policy allows. Collaboration may consider information from others such as the patient, caregivers, and other healthcare personnel, and that could include the physician, a pharmacist, and or other agency staff who have had direct contact with that patient or have had some other means of gathering information to contribute to the OASIS data collection. When collaboration is utilized, the M0090 date assessment completed should reflect the last date that the assessing clinician gathered or received any input used to complete the comprehensive assessment, including the OASIS items. When used, collaboration must concur with the appropriate time frame and be consistent with data collection guidance. Any exception to this general convention concerning collaboration is identified in the item-specific guidance. Skills check. Nurse Tisha does a start of care assessment on Mrs. Davidson on Tuesday evening, the 21st. Mrs. Davidson is recovering from a total knee replacement and will be seeing the physical therapist for ambulation and safety, while Tisha is going to instruct the patient on diabetes and medication management. The skilled nurse collaborates with the PT regarding a few OASIS items after the PT visits Mrs. Davidson on Wednesday morning, the 22nd. What will the date in M0090 reflect? In this scenario, the M0090 date should reflect May 22nd because that was the day when the skilled nurse Tisha completed the OASIS after collaborating with the physical therapist. And finally, OASIS convention regarding the term specifically and for example. The use of the term specifically means scoring of an item should only be limited to the circumstances listed. We see this in M1800 for grooming. The item states, grooming, current ability to tend safely to the personal hygiene needs. In parentheses, it states specifically, washing hands, hair care, shaving or makeup, teeth or denture care, or fingernail care. Now, since the term specifically is used in the parentheses, it means that it wants you to score this item based on the patient's ability to safely do the item specifically listed in the parentheses. Now, for the term for example, The use of the term "for example" means the clinician may consider other relevant circumstances or attributes when scoring an item. We see an example of this in M2102D. This states medical procedures and treatments, parentheses, for example, changing of a wound dressing, home exercise program. Now, because the term "for example" is used in this item, a clinician can use other items that would fall into this category, such as a patient's safe ability to check their blood glucose level on a daily basis, if that is applicable to that particular patient. That's it for the OASIS conventions. Thank you very much, and back to you, Debbie.
This concludes Session 1 of Select Data's OASIS Clinical Education. Special thanks to Select Data team members Laura Hodges and Lisa Engel for delivering this material. To reinforce what you've heard today, you are advised to refer to the session notes that will be provided for you from Clinical Services. For further reading and clarification of this manual, the session notes also contains links to the OASIS Guidance Manual, Chapter 7 of the Medicare Benefit Policy Manual, and the CMS Conditions of Participation for Home Health. All of these resources are available on the CMS website. Do you have questions about this presentation? Please contact us via email at clinical.services@selectdatacoding.com. Learn more about how Select Data can help your agency with compliance and better patient outcomes. Visit us on our website or follow us on social media. Join us for our next session, which will review the patient tracking domain. My name is Deborah Johnston, and I am the Director of Clinical Services for Select Data. I look forward to spending time with you during our next session.